Good morning. I'm really excited that the Durable people have arrived here on a rainy day in Seattle, and it's wonderful to have you here. This is yet another part of that theme of how do we both bring research to the bedside and deal with issues around bias and biases that are attached. This is part of our Sconyers-Godfrey ethics lectures, and I'm going to have Ben Wilfond from our ethics division to introduce our speakers.
Thank you, Tom. It's a pleasure to be here with you all this morning. And before I introduce Sunny and Renee, let me just say a couple more, additional words about the format here. The way this is structured, for those of you who haven't been here before, is that the first presentation is really a case presentation. It'll last for about 10 or 15 minutes, followed by a discussion of the issues raised at the end of that case by our invited commentator for another 15 minutes or so. And the idea is that there'll be a half hour for discussion at the end. And that's why we have the microphones on the two sides of the room. Rather than having one of us go back and forth with raising people's hands, we want to use the microphones because we're hoping that will actually encourage you to talk more freely. You'll be able to see who else wants to say something. You'll be able to come down to the podium, to the microphone, and we hope that'll help encourage conversation. I also, again, want to acknowledge Jeff Sconyers and Deborah Godfrey, whose generous gift many years ago really has set up this program, and it's really been very well received and a lot of fun for all of us, too. So our case presenter will be Sunny Jewell, who's the division chief for neonatology, who also is the principal investigator for a very complex multi-center trial, which she'll talk about, and some of the ethical issues that came up as part of that trial. And then our invited commentator is Renee Boss, and Renee is an associate professor of neonatology at Johns Hopkins. Her focus of her scholarship is on communication in the NICU and palliative care issues. But Renee and I have worked together. We've had a number of conversations. I know she also has an interest in research ethics issues, and there'll be an interesting opportunity for her to connect her issues in communication as it relates to the question for this case. So without any further ado, let me have Sunny come up and tell us about the case.
Thank you so much. It's been a pleasure doing this. So I've talked before about the PEANUT trial, but I'm just going to review it one more time. So the PEANUT trial, all pediatric studies need a cute little acronym, and so we spent a long time trying to figure out one for this trial, but it's preterm EPO neuroprotection. And this is a multi-center, randomized, placebo-controlled phase 3 trial, and our goal is to enroll 940 infants with the thought that after the expected mortality and loss to follow-up, we'll have somewhere around 752 babies to evaluate at 2 years of age. And I thought I would just diverge for a moment and talk a little bit about what it took to get here. So in about 1995, I was working at the University of Florida, and Bob Christensen was my division head. And at the time, I was actually doing research in lung biology, oxygen toxicity and the effect on hyaline membrane disease. And he's a neonatal hematologist. And he really wanted me to start doing research that was involved in some way in hematology. And I wasn't actually that interested in hematology. So one day he came to me with a paper that said EPO receptors were present on mouse neurons. Isn't that interesting? And I was like, well, it's kind of interesting. And so I wanted to know whether EPO receptors were present in human brain, and if so, what they were doing there. And that was really the start of my research in this area. So over the years, we first documented that, yes, in fact, EPO and EPO receptors are expressed in human brain through development. They're expressed very highly, actually, in the fetal brain and the developing brain, and then expression goes down as you age. And so we did a lot of cell culture, and then we moved into rodent models, and this area became more of interest globally, and so a lot of people contributed with piglet models, sheep models, monkey models. So there was a lot of background work that got done, and turns out that EPO works in brain similar to how it works in bone marrow. So in bone marrow, what EPO does is it protects red cell progenitors from dying, programmed cell death, and then encourages those cells to become differentiated. And so our early hypothesis was that maybe it had similar function in brain, so it would protect brain cells from programmed cell death or apoptotic cell death. And so it might be neuroprotective. So it turns out that all turned out to be true. But so 1995, there was a lot of work done to see what it does and how it does it and whether that work was reproducible. And then in the early 2000s, we started thinking about the transition from working in mice and rats to maybe thinking about it being therapeutic for humans. And so I'm not a molecular biologist, so a lot of the work that I did was focused on seeing if we could make that transition from the bench to the bedside. And so a lot of my questions were, how does a dose that's neuroprotective in a mouse relate to a dose that might be neuroprotective in a human? So what's the pharmacokinetics? Does it cross the blood-brain barrier? Is it safe? And trying to translate doses and dosing intervals in rodents to potentially therapeutic doses in humans. And so around 2008, we started doing phase 1-2 trials to understand pharmacokinetics in preemies, because that was our early focus. In 2009, I got a planning grant from the NIH to plan a phase 3 trial. And you can see it took several years to get that grant funded. So in 2013, we got a $10 million grant to do a phase 3 trial, and that's the trial that we called the Peanut trial. So the hypothesis for this trial is that early neonatal high-dose EPO treatment of extremely low gestational age neonates will decrease the combined outcome of death or severe neurodevelopmental impairment from 40% to 30%. And if you include moderate disability, it'll decrease from 60% to 40%. And our primary outcome is neurodevelopmental outcome at 2 years of age. So pretty audacious goal. This is where it's happening. We're the primary site, the CCC and the DCC, so the Data Control Center and the Clinical Center are here. And then here are other sites. And so there's 18 sites, but 29 hospitals. And so most of these hospitals require their own IRB. So it was really quite an experience to try and get the IRB through these many, many different centers. And that is actually what stimulated this ethics rounds today, because we had some IRBs that said, well, you can get prenatal consent, but not postnatal consent, because that would be too stressful. And other IRBs that said, well, you can get postnatal consent, but you can't get prenatal consent, because that would be too stressful. And we had IRBs that said, the physician taking care of the baby can't approach the mom, or research coordinators aren't allowed to approach the mom, or, I mean, there was really a variety of rules that the different IRBs put in place, and it wasn't consistent at all. This is what the trial involves. There's a lot of moving parts, as Ben alluded to. So we are allowed as a whole to enroll both prenatally and postnatally. And as you know, there's a lot of moms who come in preterm labor, and the labor is stopped, and they're on antepartum for weeks sometimes. And so this, in my opinion, it's the optimal time, because the families have time to really think about the study. They can go online and research what EPO is, and whether it's dangerous or not. But we also enroll postnatally, so we have 24 hours to enroll the moms. After consent is obtained, we get baseline studies that include a head ultrasound and then blood for EPO levels and circulating biomarkers. We get the head ultrasound because we want to make sure that even though the study is randomized, that the randomization is true for intracranial hemorrhage, because we know that that affects outcome significantly. And it was possible that just by bad luck, we could have more intracranial hemorrhage in one group than the others. So we wanted to know where we were at baseline. The other reason we did this is because it's possible that EPO is more effective if you actually have a brain injury. And so we wanted to be able to distinguish EPO effects in preemies without bleeds and preemies with bleeds. So once you're enrolled, you get EPO 1,000 units per kilo or placebo. You get 6 doses of that every other day. And then you go into a maintenance phase where you get a lower dose, Monday, Wednesday, and Friday, up until 32 weeks completed gestation. And the babies who are in the placebo group actually get sham injections. So what that means is the nurse will go into the room, close the door, fuss around with her iPhone or whatever, and then come out 5 minutes later. They put a bandage around the baby's leg. So the baby doesn't actually get a shot, because we didn't want something harmful to happen to the placebo group if they get no potential benefit. The babies get an MRI at 36 weeks if you're at certain centers that have the MRI that we needed. And then after discharge, there's phone follow-up every 4 to 6 months, and then an in-person follow-up at 2 years of age, where the babies get a Bailey 3 and a standardized neurologic exam, as well as several other parent questionnaires about the child behavior. So inclusion criteria for the study: the babies need to be born between 24 and 0/7 and 27 and 6/7 weeks of gestation. They need to be less than 24 hours old. Obviously, they need parental consent. And as I mentioned, we do both pre- and postnatal consent. IRBs differed by who could obtain consent, as well as when to obtain permission. And we actually had to have an ethics consult because of this, because our IRB said that actually the MD taking care of the patient was not allowed to approach the family. And so that was part of the peanut protocol. But we had 2 sites where there was a protocol violation, and an MD taking care of the patient got consent for a couple of patients. And this was a protocol violation that went to the IRB and the DSMB, and they suggested that we get an ethics consult. And so that's where this whole story started. So here are some questions. What are the advantages and disadvantages of excluding or requiring individuals in certain roles or certain time periods from the permission process? And might the role of the person, whether they're a clinician, a researcher, and actually sometimes these roles overlap, right? So you can be a researcher, clinician. So does that affect the parents' understanding or their willingness to participate in a study? And actually, a really good question is, do they even know the difference, right? And might the timing of parental permission influence the parents' understanding or willingness to participate? And if obtaining permission is a process, is the initiation or the conclusion of the process more important regarding timing and role? How does the NICU context influence these questions about permission? And with that, I'm going to turn it over to Renee. Oh, actually, before I do that, I wanted to just mention one thing. Times are changing, and I know a lot of people have been very downcast about NIH funding and so forth, but Congress has now appropriated actually $53 million in new funding for the NICHD $32 billion to NIH, which is $2 billion more this year than last year. So it took a lot of years to get all these things funded, but I think things are looking up. So I just wanted to leave you with that thought.
Thank you, Sunny, for that, particularly for that cheery note at the end. Let me just. And here we go here. I'll take it away.
Good morning. All right, my job now is to help us to gather together the different conflicting issues that I think have come out of the process of this trial, and then to encourage and facilitate a discussion and deliberation of the issues. I would say, in the interest of full disclosure, that I am at Hopkins, and Hopkins is a site for the peanut trial. I have no relation to the peanut trial, other than I have watched my colleagues who are related to the trial go through the process at our IRB, and witnessed a lot of hand-wringing and hair-pulling, both on the part of my researcher colleagues, as well as on the part of my IRB colleagues. So I think that there were some true questions, there remain some true questions that led to the variability, I think, in what IRBs have done about this. I would also say that the timing of this wasn't great, in the sense that it coincided with some of the press and issues around the support trial, where people became more concerned, more nervous about the safety, I think, of trials in the NICU. So, all right, so these were the questions that I was asked to consider, and I'm going to go through each one of them. Before I start, I, in my own mind, wanted to sort of clarify what I think are some of the key points of the peanut trial that are relevant to the consent process, both the timing and the role of who gets the consent. So one is that these babies are extremely premature babies. So they are the 24 to 27, 28 weekers, which means that all of them are going to be sick. And best case scenario for the most mature of them, the 27-ish weeker, is 3+ months in the neonatal ICU. Worst case scenario is that some of them are going to die in the delivery room and or in the first days or weeks after birth. So these are potentially some very sick babies. Another important part of the trial is the compressed time period when they have to be enrolled. So they have to be enrolled within the first 24 hours, and those are a momentous 24 hours. So those of you who rotate through the NICU or have been unfortunate enough to have a baby in the NICU know that first 24 hours after birth, there is a lot going on. Especially these very sick babies are getting lines, they're getting manipulation of ventilator equipment, they're starting meds, they're stopping meds, their blood pressure. We're worried about their head ultrasound. The mom's recovering from labor. We're all getting to know each other because it turns out the neonatologists have never met the family before. There's a lot going on in that 24 hours. So it's a very, very quick period. The other challenge about the 24 hours is, as someone who has tried to enroll babies soon around the time of birth, is that most deliveries seem to happen at 3 in the morning. So the clock starts at 3 in the morning if that's when the baby is born. So there's just the sort of logistical challenges, which I think in fact led to some of the conflict, some of the problem with who's getting consent is about staff availability, and we'll talk a little bit more about that. The other key study element for me looking at this study as a neonatologist is that there's a lot of detail. There is a lot going on. So there's this issue about the initial higher dose, and then there's the lower dose, and then there's the MRI, which doesn't sound like a big deal to us, but I have talked with some families whose babies have had neonatal MRIs, and it can actually be a scary process for families. It may be the first time that the baby's left the NICU ever in months. and they go to radiology, and it's a totally different staff, and so it's not a minor thing. And then there's these recurrent calls and the follow-up at 2 years. So there's a lot for parents just to sort of process about what would it mean if I said yes to this? What would our family and my baby go through? I think that the trump card of this trial is this last thing, which is that almost everybody in this trial, prior to meeting with a researcher, has been counseled that their baby may indeed die or have some degree, moderate to severe, very possibly neurodevelopmental impairment. And that is a really scary thing to think about. And I think that one of the reasons why parents may feel that they want to participate in this trial is because we don't really have many therapies in the NICU, certainly specific individual therapies that can really ameliorate these problems. So I think there's a real potential here that although parents are undoubtedly counseled that this is not necessarily a treatment to help their baby, it's research and it's to help other babies, I think that there's likely a lot of fear at the time that these parents are approached. They've just been counseled about these potential outcomes for the baby. I think there's a lot of fear about this outcome and a lot of hope that it's not going to happen to their baby. So I'll just take a few more minutes just to elaborate, because I think the context is important. The family context of what's happening when you come in premature labor at 24, 25 weeks is relevant to this story. So for most of these women, they had no idea yesterday, right? So yesterday they were pregnant and everything was fine, and then this morning they woke up and they were bleeding, or they were leaking fluid, or they were having pain, and all of a sudden they're making an unscheduled visit to their OB, or they're calling and being told, please go to the emergency room right now. They are potentially being flown somewhere or taken by ambulance somewhere. It's all happening very, very quickly, and it's totally unexpected. It's very early, so it's not uncommon that these women, they haven't picked a name for their baby, they haven't had a baby shower, they haven't any baby supplies. Like the whole process of having a baby is something that they're anticipating in about 3 months. Because of the way that regionalization of ICU care happens, it means that many moms in extremely premature baby are in fact sent away from their local community hospital to a place that could take care of a 24-weeker or a 25-weeker. So it's not uncommon in the state of Maryland for a woman to be transferred 100 miles to another hospital. And again, she didn't know yesterday that this was going to happen. So her job, her other kids, her partner's job, everything is just completely in chaos. Now, of course, a number of the reasons why women would have premature babies in the first place are because of their own medical concerns. So on top of all of this, they might have preeclampsia, they might be worried that there's an infection, there might be their own medical concerns and medications, right? So to stop preterm labor, there's a number of medications that we give, and some of those actually can alter mental status. So they may not be thinking all that clear in the midst of all of their emotional chaos. They may not be thinking all that clearly. And again, sort of this big, scary possibility that these are babies that parents are told could die. That if your baby is born today, there's a chance that your baby could die, and or if he or she survives, would do so with potentially significant disability. And at the time when the staff is coming to consent families about the peanut trial is very potentially a time very soon after when the parent's been asked to sort of make a decision about neonatal resuscitation. So I would say that these are pretty intense moments for these families when they're being approached about the peanut trial. And I think we need to remember that as we think about the kinds of conversations that are happening. All right, so let's go through the questions. So the first question was, what are the advantages and disadvantages of excluding or requiring individuals in certain roles or certain time periods from the permission process? And first, let's think about the role. Might the role of the person, either being a clinician, a researcher, a study coordinator, obtaining parental permission, influence the parent's understanding or voluntariness? And part of the reason that this is complex and why I think IRBs have come down differently about this is that there's not clear-cut guidance about who should get consent, get permission from the family in the common rule. So it does leave room for different opinions. I'd like to take a few minutes and raise sort of the pros and cons of each of the different types of people who might be approaching the family. These are not exhaustive lists, but at least enough for us to think through it together. So a study coordinator, I'm sure you all understand what a research study coordinator is. Sometimes it's a nurse, sometimes it's a PhD person. It's someone who's generally not an advanced clinician and who often works sort of 9 to 5 hours, and their job is to recruit families for this particular study. So I think some of the advantages for having study coordinators is that they're explicitly trained in the protocol and very, very clear about the protocol. So I think that they are trained and dedicated to following a clear path. A potential benefit is that they are not a clinician, and so they potentially make it more clear to the family as they go and approach them for permission that the research is aside from the medical care. So it's something separate and is not medical care. And I put here the study coordinator potentially has the least skin in the game. And after I put it down, then I decided I wasn't sure I believed that myself, that issues of conflict of interest. And I'll talk more about the conflict that the others, I think, can clearly have, but I think the study coordinator could as well. One con is that they often are not clinicians, and if they are clinicians, they're not very involved in the type of care that these babies might need, and so they might have a limited clinical understanding. And this trial is complex, so understanding what EPO might do to a 24-week developing premature baby's brain is complex. And so some of the questions that families might have about what the pros and cons of the study could be, it's possible the study coordinator couldn't answer. And then again, the logistics of it. So, the study coordinators are often not in-house 24/7 because the NIH often doesn't give us enough money to buy study coordinators who are in-house 24/7, which again has led to some of the issues with this study. So what about the researcher? What about the PI or the local investigator? Well, on the good side, they are very informed about the study's risks and benefits. Also on the good side, they're not actually the baby's clinician most of the time. And so the family might be able to separate them a little bit more in their mind from their baby's doctors. So I think there's less of a concern about blurring that boundary. But I think that the PI has a conflict of interest here, right? As with any study, their primary goal is to enroll people, right? Like that's where the bottom line is for the researcher. So that leads all of us doing research anytime we're enrolling patients to a challenge of maintaining our own equipoise about whether it's the right thing to enroll this patient. And then the other thing is that, as you mentioned, Sunny, the researcher often becomes the clinician. So even though the PI may be recruiting the family prenatally and not be caring for them and may not even care for the baby in the first week of life, may come on 2 weeks later or may come on when there's another problem and go back and forth. So the boundary is not as clear as we might like. And then the issue about whether just the baby's doctor could enroll. I think there are a number of pros really to having the doctor be the one. I think that in the best case scenario, they've already met the family. They've already counseled the family. They have some sense of what language seems to resonate with them. They have established some trust with them. And so that is very helpful in terms of the family being able to take in complicated information. They potentially know the baby's context the most, and so they can sort of put the pros and cons of enrolling this baby and the child in that individual context. They know about all the other studies that are going on in the NICU for which this baby might ultimately be eligible, and they might have some opinions about that. And I think there's some fairly compelling information that although IRBs worry and that the clinician might not be able to have these conversations with families without bias, it turns out that many patients and probably parents actually prefer to hear about research from their doctor because it's somebody that they trust and that they know and that they feel is looking out for them. Now, the cons are that it opens the door for some potential bias or coercion, right? So a con is that, as a neonatologist, if you're my patient, my dedication is to you as an individual patient. But as a researcher, my dedication is to the research and sort of to the population more at large. So I can have a conflict there. There's also, I think, more of a chance of the therapeutic misconception here, where it's harder for the parents to understand where the boundaries are about this study if I'm the baby's doctor and the one talking to them about it. And then there, depending on how it works, I mean, my understanding about how some of the challenges with who it was that was getting consent for the study in different sites was that it might not necessarily be someone who is on the ground every day getting consent for the study, and so they may not actually be all that clear about the edges of the protocol. So let's talk now about the timing. Might the timing of parental permission, whether it's prenatal, during labor, or postnatal, influence the parent's understanding or voluntariness? And I think there's a couple things to think about for timing here. So one is the timing of the study itself. This is a 2-year study and has a lot of different stuff happening at different times. So one timing thing is just sort of the process of parents thinking through, like, what's going to happen now and where might I be in 2 years? So there's that piece. And then there's also the timing that this conversation's coming often on the heels of another conversation that was your baby might die or have severe disability. So I think that timing plays as well. If we think about the differences between the family who's come in preterm labor and is now sitting in L&D for hopefully weeks, but potentially 3 days, which I think is the average, the advantage of that is it probably, given this, is the least rush time point. So it is the chance where people can read something, can have multiple conversations, and where it is more likely to be able to be done in a scheduled way by a study coordinator. So if the goal was to have the study coordinator, I think it's the easiest way. The con is, so there are some data to suggest that stress sort of promotes labor, and obviously the last thing that we want to be doing to a 24-weeker is to promote the chance that they're going to be born today. So I think that, at least in my hospital, my IRB has been nervous about letting me do something like record a conversation in the prenatal period because they thought that was too stressful and might promote labor. So this is significantly more interventional than that. Another disadvantage of this is that the baby might not be born prematurely, so there's the potential, lost resources of time and study enrollment in a mom who might actually stay pregnant for weeks and weeks and baby not ultimately be eligible. And I think that another con is that we don't actually know that the baby is going to survive. And so these families are in a sort of early grieving period. In any case, they're not going to have probably the normal delivery and birth that they thought. So I think it's a very emotional time. Now, if the mom, in fact, comes in and doesn't percolate for 3 days to 2 weeks, well, then the next option is, well, what about sort of during labor? If she comes in active labor, what about the pros and cons of enrolling her then? So certainly it's probably better in terms of timing than meeting her in that critical 24-hour period after birth, so there's a little bit more time. But it's pretty chaotic, right? So she is undoubtedly on some kinds of medications during that time point. She is worried about her own health. She may be being counseled about she's going to have a C-section, which she never thought she was going to have a C-section. So there's a lot going on in that time. And then the postnatal time period certainly has fewer pros, I think, to waiting, personally. One pro is that you, in fact, you don't put families through the burden of talking about the study and thinking about the study and being enrolled in the study if the baby's going to die in the delivery room. So enrolling postnatally means that you don't invade those families' difficult time. But there's a lot of cons to waiting till this period, and I think the biggest con is the compressed time period for parents to hear the information, to process the information, to do their own sort of research online about the information, to have the chance to talk about it with anyone else, and I worry that can undermine sort of the informed part about the informed decision process. It's also a really important time for families. They're meeting their baby for the first time. They're getting lots of information at that time from people in the NICU, right? Like, this is a ventilator, this is how the ventilator works, these are umbilical lines, they go in here, we're going to get the head ultrasound, hi, I'm Dr. So-and-so, lots of information overload, and this, I think the details of this study are complex enough that they can really get lost in that. These moms are often recovering for birth. They not uncommonly will have had a C-section, and again, it's a pretty compressed time period, so if you've only got 24 hours and your study staff aren't available, who's going to get consent? So the next question is about if obtaining permission as a process, is the initiation or the conclusion of that process more important regarding the role and timing? And it seems to me like this one is a less complicated question, because it seems to me like if we think of informed consent as the process, it's the conversation, it's the beginning and middle of this process that to me seems the most important. I think that in the beginning and middle of this, the goal is that perhaps both study and clinical staff will have a chance to talk about it with the family. They can have multiple conversations. They have time to digest the information, et cetera. I think it's less important who ultimately signs the line, right? Because who signs and sort of concludes the conversation with the family can mask a lot of things. So just because the study coordinator is the one who ultimately has their signature on the parental permission form doesn't mean that there hasn't been undue influence someplace earlier in the process by whoever initiated the conversation. And then I think the other challenge with, putting our money on who ultimately is signing the form with the family is that conversations that have been sort of ongoing, where the last step was, I'm going to come back and we're going to have a chance to talk again. If delivery happens quickly, there may not be another chance. So now it's time to sign the form. So I think that in the big picture, the most important piece of the process is the conversation. But I think it's an interesting question of it's much easier to monitor actually who signs the form with the family than it is who had the conversations along the way. And then finally, I want to spend a few minutes on this question about how does the NICU context influence these questions about permission. And I wanted to disclose that, so I'm a neonatologist. So on the one hand, I feel like I have pretty detailed and firsthand experience with the issues related to enrolling babies and families and studies in the NICU. On the other hand, I might be like the fish who can't see the water in the fishbowl, meaning that it may be that there are conflicts that I can't see because I'm too close to them. And so I'm hoping that maybe some of you all can see them and we can talk about those too. But these are what I think about the challenges of doing work like this in the NICU is that one of the pieces is that often a consent form, especially in the prenatal period, for research in the NICU is the first time that a parent has sort of made an official decision as a parent for their baby. I was on a panel at the American Academy of Pediatrics meeting in October, and on the panel was a parent of a preemie baby who talked about the experience of enrolling her daughter in a study and getting that form for the first time that said parent signature, and how that sort of just took her breath away, that all of a sudden here she was the parent and making a parent decision. So I think that the sort of emotional and psychological impact of that is an important thing to think about. Again, because of regionalization of care, these moms are often at another hospital. Even if they're in our hospital, I think many moms feel a little disengaged in the first 24 hours when they're sort of still stuck in labor and delivery. And as neonatologists, I'm sure you will agree with me, we don't do a fabulous job of getting over and talking to the mom as often as we can. So a lot of what's happening in those first 24 hours is being filtered through the family, filtered through the partner, filtered through the grandparents, et cetera. I think another thing that's unique about permission in the NICU is that parents face a lot of high-stakes decisions in the NICU. So this is not outpatient research that we're doing. This is research with very sick babies, and it is often compressed in a pretty short time period. So there's often this kind of rush in the first 72 hours or so where there's a lot going on. And ultimately, many parents, even those who have 34-weekers who are just being admitted for rule-out sepsis, babies that I sort of consider not worrisome in any way, some of those families still think that their baby is going to die, and we know that from interviewing families like this. I think another thing that's unique about permission in the NICU is that there's a growing body of data to suggest that parents, especially young first-time parents, are actually more interested in having recommendations from clinicians, that they feel less confident about their ability to sort of make a decision on their own. So I think that is very challenging because as clinicians, we're not actually trained very well to provide recommendations. I don't know about your NICU, but in my NICU, everybody's trying to recruit babies. So there's tons of studies going on in my NICU all the time, and there's basically a line. And I remember this study, I remember the conversation where this study had to get in line. Well, who's being recruited, and when are they coming, et cetera. So there's a lot of research going on, and a lot of demand for recruiting these families. So I'm going to open it up for us all to talk, but I think that the conflict about this came up because there aren't clear guidelines. And so, of course, different groups in different areas made different decisions. And I enjoyed this quote from a paper Ben gave me that said, influence is contextual and undue influence is likely to depend on the individual's situation. And that's a very complex thing to sort of wrap your hands around and measure and monitor, really. I think that having watched this trial accrue a bit and thinking through this, I think that prenatal consent in my mind seems the sanest, seems the fairest, and seems to promote parent voluntariness and understanding the most. I think that it makes perfect sense to me that they could be encouraged to talk with their clinicians about it. But I think I come down on the side of saying that I don't think that the primary clinician is probably the right one to be fully responsible for the consent process. So those are my thoughts, and it looks like we have 15-20 minutes or so to have a conversation about this. So I welcome anybody's questions.
This one was going to be a little difficult to get started, so let me give you a little context. In the last 3 weeks, we've had grand rounds on what are our hidden biases and how we provide care for folks by the color of their skin. Last week, we had a conversation about what other time do you go to the hospital with positive expectations that you do in pregnancy. So the context that you mentioned is an important one. I'm a pediatric hematologist, oncologist. I do a lot of things. I'm going to tell you that I don't think the NICU is unique. When you're in the emergency department, when you're in the pediatric intensive care unit, you're faced with exactly the same issues. Here is a patient who's arriving in extremis, who in fact may have all of the same issues. And we don't have a great track record for knowing what is the right thing to do. We have intervened with a variety of things over my career. We put intracranial monitors in patients for a long time. We put them into cool medication comas. We did a lot of things that subsequently we said, no, this isn't a good thing to do. As an oncologist, the part of consent that I deal with really is who is doing that consent, not what is their role, but what are their skills? What is their knowledge? How do they interact with the folks? And it's a challenge for us to begin to do that. Sometimes that research coordinator may be a college student and this is a part-time job, and she or he may have never thought about confronting their own death or the death of another person. And so they need some training to make that piece go along. I absolutely agree with you. The longer the time we have, the easier the process is. But when we're truly doing a life-saving maneuver early on, it's challenging. So, do we know how individuals and their skills are in conversation are influencing this activity? One of your research interests is, do neonatologists all know how to broach issues with families? Help us to understand what skills are needed.
So lots of interesting points, and I hear your point that this situation with the premature birth is more like a situation like a trauma or a patient who comes in, you know, after an accident in the ED, and I would fully agree with that, and that's why in other areas akin to that, they do sometimes a whole different approach to a consent, right? Where you essentially don't get consent, where you do things like community, you know, you tell the community basically, we're going to try cooling if you have a brain injury in a car accident, and we're not going to consent you, and if you come to our hospital, you're going to be in this trial. So you're absolutely right. As for the communication skills, I think that the answer is that we don't know very well. We know that in framing matters. That's clear. So if I tell you that there is a 20% chance you're going to die, or if I tell you there's an 80% chance that you're going to live, that you process those things differently. And so framing matters. And finding the way to give individuals the communication skills so that they can be consistent depending on who's facing them, right? So at Hopkins, we sometimes have patients who are physicians, who are cardiothoracic surgeons who are having babies, and sometimes we have patients who are 15-year-old moms who are having babies. And so it's not even just about the skills that I have to say the words, it's about how I can have those conversations differently depending on who's in front of me. So what I would say is I don't think we know what the best way is, and partly that's because the research on this topic is more weighted towards what researchers think we should be doing and less weighted on what patients think we should be doing. So there's more interesting research happening in the last 5 to 10 years about that, but up until now it's mostly been what do we think we should do. And I think in general, you know, sort of the field of looking at communication skills and how that changes decision making is still a new area that we don't know enough about.
Thanks very much. I think this was a very nice summary of a lot of the issues that are involved in this kind of research. And I'm an oncologist as well, and it's certainly relevant to what we do. Just a couple of observations or thoughts. One, I think it's useful sometimes to step back and think of, if I was a parent, what would I want here? And I think with this kind of study, the stakes are high. This is big deal stuff here, potentially. It's a study, we don't know, but from the parent's perspective, the reason we're entering it is because we hope. And I think that from that point of view, the more we can do to facilitate the opportunity for patients to participate if they want to, as a parent, that would be important. I think the last thing I would want is for somebody to have made some sort of paternalistic decisions that would limit my ability to participate in the study. The second point, I think, is one of the things we're beginning to learn, at least in the oncology world, is that people don't remember what you said in a consent form. They don't. They really don't. And so and couple that with the concept that consent, and you touched on that, consent is a process, but it doesn't by any means end at the time of the signature. It is, and I think the way we need to really think about these studies is our real obligation is to make sure we're offering the opportunity for reflection. The major bulk of this study is going to take place after the parents have had to settle down, and that's when we should be, I think, reconsenting, asking the families whether they really understand what they signed up for or not. So my thoughts about that.
So two pieces to what you said, and I'll address the second first, is that totally agree with you. What I would say is the idea that parents will have multiple opportunities to drop out, that we will actively give them multiple opportunities to drop out, scares researchers. So that's one of the challenges of it, actually, is that is the worry that keeps saying, are you sure you would still want to keep going, is somehow going to cause this problem. So that's one piece. The other piece is, I would say, there's a lot to be learned from the oncologists in terms of consent and study enrollment, because your families and patients participate at a very high rate. And I think your point about the hope, that people enroll with hope that it's going to help your baby is a complex thing. And you know, this concept of therapeutic misconception has been around for a bit, but I think there's some work to be done about whether or not that is always bad from the patient's point of view. So again, learning more for what the families want is important. Ben?
Renee, first of all, thank you very much. That was a really terrific review of the issues. I want to ask you a question about your recommendation regarding the second phrase in the word responsible, and what you mean by the clinician should not be responsible. Because I could imagine meaning a couple of different things. They should never be involved, or it could mean that they should not be the exclusive person only involved. And the reason why I'm bringing this up is, again, the issue that Sunny raised when this came up was this question of who got consent, because it always boils down to a identification of a person. And even though you point out maybe multiple people involved, is your point that it's okay to, as long as a researcher was involved at some point, then the clinician can have can sign the form? Or say more about what you visualize for this.
Thanks for pointing out my attempt to obfuscate the answer to this, Ben. I think after reading a fair bit about this, and actually your work, the study asking patients who they wanted to approach them about research is a pretty compelling piece, I think, in terms of convincing me that in general patients want their doctors to be involved at some point in this process, and that they are in general reassured by that, and that without that they are worried that they're making a bad decision. So I feel comfortable saying that the clinician should be involved. I still feel worried that not having sort of the researcher themselves driving part of the process makes it dilutes, I think, or makes the boundary between research and clinical care too blurry. It feels to me if there's no research staff in here clearly identified as research staff, and this is a research study, that boundary is going to be difficult to see for stressed families. Fair? Fair. Okay.
Hi, I'd like to preface my remarks by saying I'm not an MD, and I know you all have thought on this for a long time, but I wanted to emphasize, based on my earlier work experience as a patient care coordinator, doing the consent process, permission process in neuro-oncology, and I found in that when the physician researcher asked me to go in and obtain consent, that I was uncomfortable with it. And I think, as some people have said, you didn't have experience before that, if you were fresh out of college, I don't think you'd have the wherewithal as the research coordinator to go back and say, I'm really not comfortable with this. So what I did for myself was I would go in and go through the protocol, make sure the patient understood it, and then ask for the physician scientist to come in at the end and said, do you have additional questions? And for that study, the reason I was uncomfortable is because I didn't feel like the patients understood a lot of times that if they consented to be in this trial, that it would exclude them further downstream from being in other studies. And I think that would be really important for this topic as well, just that they don't understand.
And can I just
that
ask, so was it true that the physician scientist coming behind you made that clear, or?
I think the important piece was because they had the knowledge for that particular patient about what other studies they might be eligible for or excluded from, and if being in this trial would exclude them from other ones that would be appropriate for them, that they had that piece to really explain that I didn't have. And then the other thing from my experience was that the patients really wanted to speak with a physician, and it was that deeper trust and the context and wanting guidance and their opinion, which again could be an undue influence, so there's that caution, but that's really what the patient wanted. And you would hope that, I think I'm right, that the physician then has that duty to the patient more as the physician rather than the researcher, to really try to do what's in the best, to give the guidance for really what's in the best interest of that individual patient.
Yeah.
So just
Yes, I agree
further
with
tangle.
that. Yeah, I agree with that. I would also say, as someone who does research, that the question of the attending physician getting consent is a workflow complication. If I am lucky enough to get a grant from the NIH, the salary allotment for the study coordinator is different than for me. So it's more expensive in the end to have studies where the attending physician or the PI is the one who has a very concrete responsibility in the consent process. I'm not saying that it shouldn't happen. I'm just saying that one of the considerations to think about as we consider, and our IRB is clearly moving this way, as we consider a model where the study coordinator is no longer allowed to officially get consent, but in fact it must be the PI or another physician on the study, that there are some questions about, well, how is that time to be funded, and how is that going to change the way research flow is happening?
Right. And it also for the research coordinator, knowing that the physician's time is so constrained, that's also difficult, I think, a lot of times for us to go back and say, I need you in this room. I really don't feel comfortable with this.
Yeah, no, I hear you loud and clear, and I think that was your first point, right, was that, many study coordinators may feel unprepared for this and not have the communication skills to speak up to their boss and say, hey, this is not okay.
Right.
Yeah, thank you.
This question may be slightly off track, but what do you see the ethical considerations around answering parents' question, Doc, if this were your child, what would you do?
That's simple. About research or clinical care or anything?
Well, let's start with research, I guess, in that.
Yeah. I can tell you what I think. I can tell you that there's no consensus about this. So you can probably imagine the potential responses as well as I can. I think, our group has done a little bit of work to see, well, what does happen when parents say, Doc, what should I do? And what mostly happens is about half of doctors go, I can't make that decision. Even the more articulate version of is, I'm not you. I don't know your family. I don't know your values. I can't make that decision for you. It's a very individual decision, right? So many people want that answer because I think, I wasn't trained necessarily to say, Mrs. Jones, given what I know about you, I think you should do X. That's a little different from your question, which is how should this be done? So how it is done, I think, is that mostly we try to get out of making a recommendation in that situation, and probably what's happening is it's idiosyncratic, that each person in this room is doing what they do in the moment with that parent. I think that when I've been asked that question and have given an answer that was something besides I can't answer that, which was more like, I'm not in your situation, but given what I know about this and given what I know about your baby, I think it would be okay to do X, or I think that I would do X. Most families seem reassured by that, and not all of them do it. So it doesn't feel to me terribly coercive, because some families still say, yeah, it doesn't sound right to me.
And is that an issue that should be specifically addressed by IRBs with some kind of a script?
That's a really good question. I don't know. That's a very good question. I think because we don't know really. As a researcher, what I would say is, first, what we need to know is whether people want that or not, and what happens when you answer both ways in order to write that script. Because otherwise, I don't know what the right thing would be to say in that script. Ben, you have an opinion?
No, unfortunately, I have lots of opinions about that, but we can talk more later too. But unfortunately, we are out of time, so I want to thank Renee and Sunny for the presentation, and enjoy the rest of your day.